Hi, everybody who's just joining the webinar today. Really happy to have you here. We're just going to leave one more minute for a few more people to join, and then we'll get started. Thank you. All right, good morning, good afternoon, good evening to everybody. Thank you so much for joining this webinar today on quality of care in pneumonia. We're really happy to welcome everybody with this webinar sponsored by R4D and RTI. Just a few housekeeping rules before we get started. We're going to be recording the discussion today, and we'll make that available afterwards for people to access. If you have any questions throughout the webinar, please do post them in the Q&A chat. Then we'll either answer them directly or they'll be brought up in the panel discussion. So please, any clarifications and questions, please be active in the Q&A. And finally, just in case the worst happens and we get cut off for any reason, please check your email. We should have a new link sent out to you so we can restart as soon as we can. But now we'll go ahead and get started. So I'm Dr. Carina King. I'm an associate professor at Karolinska Institute, and I'll be moderating the webinar today. And just to give a bit of background for why we're here, why are we talking about this topic? So as was highlighted in the recently published Missing Piece report from the Every Breath Counts Coalition, pneumonia continues to be the leading cause of infectious mortality in children under 5. And the COVID-19 pandemic, when that come along, it's really just exacerbated a lot of those root causes and really highlighted the issues in some of those root causes for why pneumonia remains such a leading cause of morbidity and mortality. A few notable causes of this are access to oxygen, but also inequitable access to resilient health systems where the burden of disease is really the highest. This is made worse by the fact that pneumonia has historically received lower levels of funding than other infectious diseases. In fact, between 2007 and 2018, it only received 6% of the research pot for infectious disease research. And most of that money went to vaccine development rather than diagnostics and health systems initiatives. So it's abundantly clear that more efforts are needed to prevent, diagnose, and effectively treat childhood pneumonia if we stand any chance in achieving the Sustainable Development Goals by 2030. So while we still need to improve vaccine coverage, reach zero-dose children, improve nutrition, and efforts to reduce air pollution, with air pollution being the theme for this year's World Pneumonia Day and being discussed at COP26 this week, really, we also need to look at the health system capacity to manage pneumonia. Low cost effective antibiotics exist, but access is not always there and it's not always equitable. And we see a similar situation for oxygen treatment for those who are most severely sick. We know it's an essential medicine, but that not everyone can access it. But before we get to treatment, first and foremost is the ability to diagnose accurately a child and know who needs to have antibiotics and who doesn't, who needs a referral to hospital and who doesn't. The diagnosis of childhood pneumonia in low resource settings still relies on the manual count of how many breaths a child takes over a 60-second period, a practice that's known to be challenging for a multitude of reasons. This starts with healthcare workers having to have the right knowledge of which children should be assessed, having a timer available and adequate space to do the measurement, interpreting the result, being able to prescribe the correct treatment. Unpacking how these challenges apply in different contexts requires digging into knowledge and skills, otherwise known as the know and can in the know can do gap. So I'm really excited that we're going to hear about research and programs that have been done on this topic from RTI and R4D on the evidence of quality of pneumonia diagnosis from both Tanzania and India. And then we have the privilege of hearing from a diverse panel of experts, including clinicians, government officials, donors, and implementers on how we can work together to really tackle this fundamental issue in pneumonia quality of care. So I want to begin today's discussion with a presentation by Taylor Salisbury from Results for Development. Taylor will be presenting findings from R4D's recently published study, Correct Diagnosis of Childhood Pneumonia in Public Facilities in Tanzania, a randomized comparison of diagnostic methods. So with that, I'd like to hand over to Taylor.
Thank you, Karina, and thanks everyone for being here today. The study that I'll be talking about today is part of a much larger collaboration between Government of Tanzania and the market shaping team and the evaluation and adaptive learning teams at Results for Development. And I'll talk about the study in a moment, but just quickly for those of you who might not be familiar with R4D, we are a global nonprofit that works with a variety of different types of stakeholders, particularly in health, education, and nutrition. And most of our work is focused on supporting those stakeholders as they work to strengthen systems and institutions, both globally and in the countries where they work. And this map here, you can see the scope of all those many partnerships and the various different countries that R4D works in. Tanzania is one of our focus countries, and I think the study that I'll talk about today is a really good example of those partnerships coming together, and in this case, filling a knowledge gap that we saw as we started our work on this project focused on pneumonia. So background on the study itself, as I said, it's part of a much larger collaboration with the government of Tanzania that focuses on procuring amoxicillin dispersible tablets as the first-line treatment for pneumonia in Tanzania, procuring amoxicillin dispersible tablets and then distributing them within the public health sector. That the overall goal of making sure that more children have access to medicine when they need it, but making sure medicine is on the shelf when a child needs it is only part of the picture. And so also, as Carina was mentioning, it requires a correct diagnosis in the first place. It requires the provider to provide a correct prescription so that that medicine actually ends up in a child's hands. And so as we started this work in 2016, 2017, we wanted to understand that broader context for how the medicine, once it actually ends up in a facility, how might it actually be used? And at the time, there wasn't a lot of information to fill in some of those knowledge gaps. And so this study came out of that need. And the study itself focused on two specific research questions. The first of which was, do providers follow the IMCI protocol for diagnosing childhood pneumonia? IMCI being the standard of care in Tanzania, and as Carina mentioned, the different steps as part of IMCI need to be carried out in order to get a good result with that as a diagnostic tool. And so we wanted to see, do providers actually carry out each of those individual steps of the protocol? Do they count breaths? Do they look for chest indrawing? Do they listen to the child's breaths? And then our second question was, what's the correct rate of diagnosis and prescription for childhood pneumonia? So how accurate are providers as they treat children under 5? And to answer those two questions, we put together a study that had 3 key components. The first of which was direct observation. So we sent enumerators to public health facilities across the country, and each enumerator would go to a public health facility. They would identify one provider in the facility who treats children under 5, and they would observe the provider as they conducted their regular examinations. And they had a checklist. And so each time a provider conducted one of the IMCI steps, they would tick a box. And that's how we determined whether they were following the IMCI protocol or not, the basics of that. At the end of each examination was our second step here, which is we recorded the diagnosis the provider gave, whether it was pneumonia positive or pneumonia negative. If the result was pneumonia positive, or if the provider gave some other diagnosis that was respiratory in nature, or if the provider had or if there was some sort of respiratory condition, the respiratory symptom the patient was exhibiting, then the child would be referred to another room in the facility where we had a technician who was waiting to conduct a re-examination. And the technician was part of our study team. And each technician had a portable lung ultrasound machine. And they would use that lung ultrasound machine to scan the child's chest and use the result from the ultrasound examination as our reference standard for deciding the rates of underdiagnosis, overdiagnosis, correct diagnosis. So we compared the ultrasound result to the provider diagnosis, and you'll see there in the bottom right-hand corner how we determined the rates of misdiagnosis. We had, in the end, we had about 850 children in our sample across 83 facilities and 3 regions in Tanzania. And now for some of the findings. So our main headline finding was that most children in our sample were actually being misdiagnosed for pneumonia. So if we visualize it as for every 100 children who were diagnosed with pneumonia according to the lung ultrasound result, about 18% were actually correctly diagnosed as having pneumonia. So that's 18% where the provider diagnosis of pneumonia corresponded with the ultrasound result of pneumonia, which means that a very large portion, about 80% of the children were being underdiagnosed for pneumonia by their provider. Now, this high rate of underdiagnosis doesn't necessarily mean that a child walks away without a prescription for a correct prescription. So in our case, actually about 50% of the children who had pneumonia according to the lung ultrasound result actually still walked away with a prescription for amoxicillin, because providers tend to still, even if they don't diagnose pneumonia, they will still prescribe some sort of antibiotic. In a lot of cases, it is amoxicillin, and so a lot of children still end up with the correct prescription. Main caveat I'll make is that IMCI, as Carina mentioned at the top, is imperfect. One study we saw noted that if you do IMCI correctly, you can identify as much as 70% of the cases. So if we take that as our comparison point, we still have a pretty large gap in terms of accuracy, 50 percentage point gap between what is possible and what we observed in our sample. And with this gap here, I think the question is, well, why? Our study was meant to measure this rate of misdiagnosis in the beginning, and so we weren't necessarily set up to look at causal links. But we did collect this information about whether providers are following the IMCI protocol. We did collect provider characteristics, and so we did look at some of the correlations as a start. Future research would be needed to fill in some of those gaps, but as a start. And what we did find was that in this case, in the facilities where we're in Tanzania, across the 3 regions, there is a no-do gap. So we asked providers about their knowledge of pneumonia treatment, and most of them were able to describe the different steps for the IMCI protocol that they should be following. But then from our direct observation, most of those steps weren't actually being carried out. So if we look and say, well, if the provider conducted at least one IMCI step, any of the steps, only about a third of the children actually received any one of those steps from the IMCI protocol, which means that about 2/3 of the children, the provider was basically taking a case history or asking questions of the caregiver was the primary way that they were diagnosing. So we do see a no-do gap here in this context, and my colleagues at RTI will talk a lot more about the details of that in the context of India. but we also did see it here in this study in Tanzania. So those are some of the key highlights I wanted to share. Before I pass it back over to Carina, I did want to acknowledge our many partners for this work. Several Governor of Tanzania partners, including the Reproductive and Child Health section of the Ministry of Health. The Muhimbili University of Health and Allied Sciences was our partner in training the ultrasound clinicians and technicians. ID Insight as our NGO partner to design and implement the study, and then EDI Global, who is our data collection partner and help make sure that we collected high quality data for this study. So thank you to all of them, and thank you everyone for being here, and I'll pass it back over to Carina.
Thank you so much, Taylor. And I think this study is particularly interesting for the use of portable lung ultrasound as a validation tool. So it's a really nice research study to see. So next we have a presentation from Lopamudra Saraswati from RTI International. And Lopa is going to present findings from RTI's study in India, the gap between knowledge and skills related to childhood diarrhea and pneumonia among frontline workers in rural Uttar Pradesh. So I hand over to you, Lopa.
Thank you, Karina. Good morning, good afternoon, and good evening to the respective people. I'm delighted to have the opportunity to present our study findings from our frontline health workers survey in India to measure their knowledge and diagnostic skills around childhood pneumonia. I will start with a brief overview of our organization, then provide a background of the overall project under which this study was done, following with the main study findings. Next slide, please. Next slide, yeah. The study was done by RTI International, which is an independent non-profit research institute headquartered in the US's North Carolina and offices in many other countries. Next slide. RTI's India office is a fully owned but independent subsidiary of RTI International, headquartered in Delhi. We share the same ethos as our parent organization. In India, we work on the 5 verticals as mentioned in the slide. Next slide, please. We try and address world's most critical problems with science-based solutions with a mission to improve the human condition by turning knowledge into practice. Next slide, please. The study I'm going to present today was done under the umbrella project called REACH, Research and Evaluation for Action in Child Health. This was developed by RTI with Bill and Melinda Gates Foundation to support the measurement, learning, and evaluation efforts of an intervention to improve quality of care for childhood pneumonia and diarrhea, implemented by Care India in Bihar and by University of Manitoba through India Health Action Trust in Uttar Pradesh. And next slide, please. There were several study components in the REACH project. There were 2 rounds of quantitative surveys to measure the impact of the intervention, and at the end, a qualitative inquiry and a pause and reflect session for evidence synthesis and formulating actionable recommendations. At the baseline, we conducted a community survey and a frontline health worker survey. Facility surveys, including a supply audit, a provider assessment, and an inpatient and outpatient survey were done in both the rounds. Today, I'm going to present the findings from our frontline health worker survey, taking data only from Uttar Pradesh. Next slide, please. The findings have already been published in the journal Tropical Medicine and International Health. I will start by presenting a conceptual framework which we have proposed in our paper. The framework is to identify the gaps that exist at different points in the pathway from knowledge to practice. For any disease management, all these gaps are blanketly termed as the no-do gap in literature, which essentially means the failure to provide adequate care despite having the correct knowledge. In our framework, we have shown 4 important elements of care: availability of evidence-based guidelines, providers' knowledge about what they should do, which we term no, providers' skills in putting that knowledge into practice, which we term can, and providers' actual practice, which we term do. The provider's ability to perform well on any one of these elements often does not result in good performance on the next level, resulting in gaps between knowledge and skills and between skills and practice. Tracking the pathway of translation from knowledge to practice is important, especially for childhood pneumonia, which requires high level of assessment skills. Our study was specially designed to measure the gap between frontline health workers' knowledge of the science of pneumonia and their skills to identify the signs, and that is the know-can gap. Next slide, please. Our survey respondents were public frontline health workers called accredited social health activists or ASHAs, who are trained female community health workers present in the villages of India, and private frontline health workers called rural medical providers or RMPs, who could be any medical service provider in the rural areas of India, starting from pharmacies to other informal providers. We call them private frontline health workers, as most of the time in rural India, they are the first point of contact for the care seekers. ASHAs were selected using a two-pronged approach, one from the villages where community survey was done, and the other from the catchment areas of the facility surveys. RMPs were selected only from the villages of the community surveys. The detailed sampling strategy has been published in the paper I have just mentioned. The data I present here is appropriately weighted. Next slide, please. We assess the provider's knowledge by asking them what are the key signs of childhood pneumonia. And if they reported back mentioning both the signs of chest indrawing and fast breathing, they were considered having the correct knowledge. For assessing skills, we showed them some video vignettes developed by WHO and contextualized in India for FIMNCI training. If they were able to identify the signs of chest indrawing and fast breathing from the video, they were considered to have the skills. If a respondent had the knowledge of a sign but did not have the skills to identify the sign, they were considered to have a no-can gap in pneumonia diagnosis. Next slide, please. In the next few slides, I will be presenting the findings of this study. This graph shows our findings on respondents' knowledge and skills around pneumonia signs. The dark blue bars present the proportion with correct knowledge, and the light blue bars present the proportion with appropriate skills. We found that both among public and private frontline workers, the knowledge of the science was low to medium. Nowhere it actually exceeded 40%. Skills of identifying the science were even lower, as low as 2.5% of the ASHAs had the skills to identify fast breathing. Other proportions were all below 20%. The gap between knowledge and skills was statistically significant for all the signs for both types of respondents. This highlights the existing no-can gap among them. Next slide, please. We have run separate regression models for predicting knowledge and skills. The first diagram here with the blue dots presents the adjusted odds ratios from the multivariate logistic regression to predict the knowledge among ASHAs. The independent variable with an asterisk that has been put in the yellow boxes, that is receiving training on ASHA module, receiving focus training on childhood pneumonia management, and receiving related information from the television, were significantly associated with correct knowledge. The ASHAs who received training on ASHA module or a focus training on pneumonia, as you can see in the diagram, had twice the odds of knowing the correct sign than those who did not. We ran bivariate logistic regressions to predict the presence of skills among only those who had correct knowledge. We could not run a multivariate regression because we did not have sufficient sample for some of the variables. And we found that the variables related to training failed to have an impact on their identification skills. Next slide, please. In the next slide, we present similar analysis done for the RMPs. Again, here, receiving focused training on pneumonia management was significantly associated with correct knowledge. However, we did not have sufficient sample size to run the regression for skills with training. Next slide, please. So this slide summarizes the regression analysis I've just presented in the previous two slides. We have highlighted the sales that showed significant association. None of the factors that were associated with correct knowledge were associated with appropriate diagnostic skills. So we conclude that intervention aiming at increasing only knowledge is insufficient to improve the diagnostic skills for childhood pneumonia assessment. I hope these findings will be helpful in informing the programs to address childhood pneumonia. Next slide, please. I thank BMGA for their support in this study and the program partners, University of Manitoba and IHET for their feedback. I also thank the study participants for their immense contribution. And I thank all of you for patiently listening to my presentation. Thank you.
Thank you so much, Lopa. Another really interesting presentation and such a clear demonstration of that gap. You really brought that to life, the issue. So with those two presentations, this brings us on to our panel discussion, where we will now kind of take those two pieces of evidence and try and discuss why they're there, how we can try and address it, and how do we move forward. So I'm really happy to introduce our panel members today. We have 6 fantastic panelists. We have Dr. Mwanidi Amiri, a pediatrician from Muhimbili National Hospital in Tanzania. We have Dr. Ntuli Kapologwe he's the Director of Health Services in the President's Office in Tanzania. We have Dr. Sumita Ghosh, the Additional Commissioner for Child Health at the Ministry of Health and Family Welfare in India. Dr. Priyananda, Senior Program Officer from the Bill and Melinda Gates Foundation. Mr. Kina Baker, the Head of CSR from the Philips Foundation in India. And Dr. Anna Ditchin, Child Health Specialist based at UNICEF in New York. So really a fantastic set of panelists. And I'm going to start by posing some questions to each panel member, and then we will take some of the questions that are coming through the Q&A to pose to them as well. So please do keep submitting questions. We've seen some great ones so far. But I'm going to start my question with to Dr. Mwanidi Amiri. So Dr. Mwanidi has served as the Head of Pediatrics and Child Health, Head of the Department of Pediatrics and Child Health at Muhimbili National Hospital in Tanzania for the past 3 years, and received her Doctorate of Medicine from Muhimbili and a certificate in quality improvements for health system strengthening from the University of Heidelberg in Germany. She's also a very active member in Tanzania's Pediatric Association, so has a huge amount of experience to talk to us today. And the question I'd like to pose to you is, both presentations we've heard have shown how not only high rates of misdiagnosis exist, but that the interventions used to try and improve knowledge don't necessarily translate into healthcare worker skills. So as an active clinician in Tanzania, is it clear what might be causing somebody to know how to diagnose, but then not have the skills to do so?
Thank you very much, Carina. Thank you, Lopa and Taylor, for this very interesting discussion on these important papers, which have highlighted pneumonia in under 5. From my perspective, the reason why it might cause someone to have the knowledge to diagnose pneumonia, but yet does not have the skills to do so, my thinking is that I'm looking into the, starting from the pre-service training. Looking the pre-service training, I'm thinking on the, yes, you have received the knowledge, and did you get the enough skills while you're doing the pre-service training? Because if you get the knowledge is one thing and practice is another thing. Then my next point will be looking on the exposure. Yes, do you have the exposure to the training? How many trainees per the tutor? so that you can instill the knowledge that we intend for the candidate to come up with enough skills. Because we need to have a translation from the knowledge that you have acquired and the skills so that you can make the right diagnosis, especially in pneumonia, and have a good plan of management. Another thing is and also in the course, if you have a short course, that means even the exposure to the clinical skills might be constrained. Another thing was is there enough supportive supervision because these are the primary level of care and secondary level of care healthcare providers, which we need really to impart them with skills so that they will know when to refer, when to treat as pneumonia, when to refer when they are under 5 are critically ill or they have only pneumonia, as has pointed out that despite having only 33% whom were received the proper IMCI, but 50% ended up receiving antibiotics. So it is necessary to have those skills so that we can avoid also over treatment in case pneumonia was not diagnosed there. Another thing, I'll look on the quality of care provided. Is there any quality audits? If you look on the quality audits, this is something, if it's done, it will help to know the skills and the care that is given, because if you look on the vitals that were checked, was the patient assessed? And also, was there any thorough examination that were done? Do they are there to the SOPs? Because you'll see all the parameters there, but if you look on the skills attained, and also another thing that I was thinking is looking on are there available job aids, enough job aids, at least to remind, is there any refresher course after, then this will be the in-service now, the refresher course. So those are the different things that one might think to look on this nook and gap that was identified. But I think there is still a room to for more research on this, especially looking on the making it a generalizable result by looking in the bigger perspective, because as you can see, there are only 3 regions that were involved. Yeah. Thank you, Karina. Back to you.
Really valuable insights. And you've mentioned a few things in here, but I just want to follow up. So on your experience, what tools would you like to see prioritized to improve skills at kind of lower level facilities? So what would be the key things that you would like to see?
Okay, so among the key things as a clinician working in a national hospital, which is also a teaching hospital. So what normally helps to improve skills is the teaching session that we normally do. Like if we invest on the teaching ward rounds, you do a real-time assessment of the undergraduates, residents, house officers. So this is important, and also to do the clinical simulations. You impart knowledge because they know what to do, but you need to see, do they have the enough skills to diagnose pneumonia. Another thing will be also, because it's also a teaching hospital, yes, we are doing in the precepts training, because we are supervising and treating and teaching the undergraduates. So we instill the skills in the pre-service. So when they come in as practitioners, they show the skills. This is very helpful. But also the refresher courses that they do while they're in service. This is important for them. And also, like for instance, we are doing the workshops. Like currently, we are about to do the neonatal workshop. So we'll still the skills in neonatal resuscitation. So this should be done also to focus on the under 5. Another thing is another thing that we can do is mentorship and supervision. We as the national level at the tertiary level, we can supervise the primary and secondary level of care. As currently the Pediatric Association of Tanzania, we have this clinical learning network initiative. So this initiative also, they did kind of the same thing, looking on the under 5 diseases. So one of them being pneumonia. So this is an eye opener that if this is highly emphasized, we can impact skills. So like the Pediatric Association of Tanzania, we are the ambassadors. We can disseminate the skills and assess and see if there is an impactful skills in the community. But another thing that will be highly emphasized is the quality audits. If we do the quality audits and look on how do we give the service from the primary level of care, how do we do not only the outpatients and also the inpatients to see the quality of care, how many are diagnosed, like properly diagnosed, only even the clinical aspect, and how many are referred. Because if you diagnose early, you will refer them early and you will treat them early. Then even you reduce the morbidity that might be accompanied by the pneumonia. But another thing that we can do is that if we invest also on the telemedicine, we can involve the primary level of care. We can involve them and show them the real time. You do this, they present a case, you see how they examine and how do they manage. You can correct them and improve skills. Another thing is for us to do outreach programs. These are the things that if we look at them, doing outreach program to the lower level and also in our level, because not all, it's not that being a national hospital, then you'll be doing all grades. So these are the things that you need to add more skills and refreshing the skills. And that's why this comes the importance of CPD, which is currently highly emphasized. For you to have to renew your registration, then you need to have certain CPD number. So it's important because this will impact also, you have an impact on the skills. I think that's what I will say so far, unless if you have another thing. Back to you, Carina.
Thank you. I think that's such a wonderful list of very actionable things, very pragmatic things. So thank you. I really appreciate that response. We're now going to move on to ask questions to Dr. Ntuli Kapologwe. He is the Director of Health Services at the President's Office, Regional Administration and Local Government in Tanzania, and was also a co-author with Taylor Salisbury and the others on the study that R4D conducted to understand the rates of correct diagnosis of childhood pneumonia in Tanzania. If you do have a video, we would love to see your face, but appreciate if that's not possible. But the first question I'm going to put towards you is that R4D study highlighted the high rates of missed pneumonia diagnosis. So we've seen misdiagnosis, but also missed pneumonia diagnosis in Tanzania. So how are these findings useful for informing the government strategy to improve the quality of pneumonia diagnosis? So how will you take those findings forward?
Thank you very much for this opportunity, and I'm really very sorry I cannot switch on my video due to the internet challenges, but I'd like really to commend the two presenters for their very good presentations. Mine actually being a director at the President's Office, my role mainly is to make sure that we
It's just cut out.
Can you hear me now?
Yeah, you've just come back. Yeah.
Yeah, so being the director, my role mainly is to supervise the implementation of policy and guidelines at the regional and district level. And we have around 6,000 primary healthcare facilities across the country where we actually provide them with capacity building and also provide them with necessary support for them to be able to execute their duties accordingly. Now, based on the research findings from the study, which I was part of it, really, we as a government of Tanzania now, we actually had to convene a stakeholders meeting to strategize how best we can address a couple of things which were found out of this study. First of all, we did engage our colleagues from the Ministry of Health and also the Pediatric Association of Tanzania to discuss some of the things which we felt that were important for us to be able to address a number of issues which were actually found in this study. One of which was to ask the Pediatric Association of Tanzania to assist us with the supportive supervision and mentorship program, but at the same time to actually discuss with them on the issue of outreach and mobile services. Tanzania is quite a huge country, so we have close to 6,000 primary health facilities across the country. So you need really to have different strategies for you to be able to reach out to all healthcare providers across the country. So in the meantime, also we are investing on the telemedicine, being part of the initiative, also to reach out to the frontline workers so that through the telemedicine, they can benefit from those who are working at the secondary and tertiary level. The way the healthcare system of Tanzania is organized, it assumes the pyramid shape. So at the base, we have the community, followed by the dispensary, then followed by the health centers and the district hospital. And these four layers forms what we call the primary healthcare. Then from there, then we have the regional referral hospitals, we have the zonal hospitals, specialized hospitals, and the national hospital where my colleague from Muhimbili is working. So for you to be able to benefit from those who are at the apex, you really need to have a very good information system and a very good platform, different platforms, one of which is telemedicine. So we have actually identified 3 hospitals which are working as zonal hospitals together with the national hospitals, where our colleagues who are working at the district level, they can get actually assistance in terms of reading the X-rays, ultrasound, and all related diagnostics at the primary healthcare level. That's one. But the other thing, it was to actually work with our colleagues from Ministry of Health to make sure that we disseminate now the guidelines and also the treatment guidelines, which enables now our colleagues at the primary healthcare facilities to be able to diagnose correctly, but at the same time, they should be able to manage cases accordingly. So this is what we have been able to do. But what I can say, the knowledge gap actually increases as you go down the pyramid. So as you go from the apex going down to the base, then the knowledge gap becomes more and more obvious. And even the deployment of the staff, those who work at the base of the pyramid is different from those who are working at the national and zonal hospitals. So you need really to have a very good structure of assistance from the national to the actually the primary healthcare level. So this is what we've been able to do. After receiving these results, but it's still a work in progress. And we believe that with the assistance from different partners, we'll be able to really help our colleagues to diagnose a pneumonia correctly and offer the right treatment to the children. Thank you.
Mm-hmm. Thank you. And I think some really interesting points there about everywhere not being the same and the different levels of the system having different issues. So from your perspective, what additional information would you like to see to help you move to the next step?
For now, I think we need a number of innovations. As I said, you know, we are the gateway to 98% of health facilities across countries. So the primary health care in Tanzania constitutes 98% of facilities. So the regional hospitals, the zonal and national hospitals just constitute 2%. So we need to have technology which will help the frontline workers who constitute the big portion to benefit from those who are working in these specialized zonal hospitals and also the national hospital. So we were of the opinion that maybe we need to have tablets, or we need to have, for those who are frontline workers, to assist them to be able to use them at that lower level, but also to try to use these different platforms, including webinar. Now the Pediatric Association of Tanzania, they are coming up with several innovations, and also together with the Minister of Health on how to assist those frontline workers. So I believe with those approaches, then we'll be able to build the capacity of those lower level healthcare providers, but at the same time, capacitate them to be able to actually discharge their duties accordingly. But recently, we also find out that the research capacity, both institutional and individual research capacity, is quite very low at the primary healthcare level. Thus goes hand in hand with the low data use at the lower level. So we believe data use at lower level, having research capacity can be an impetus for those frontline workers to be able to manage well and also to be able to improve their practice. So these are some of the things we believe maybe identifying a partner with whom we are going to work together, it can help to improve our service delivery at the lower level.
Thank you. And I think we should have partners on the call today. So that's a nice call out to people on the call if you want to respond. So thank you so much. I'm going to move on now to our next panelist, Dr. Sumita Ghosh. She is the additional commissioner in charge of the Ministry of Health and Family Welfare in the Government of India. And she's a pediatrician by education with 35 years of experience. And in her current role, she's the technical lead at the ministry, providing guidance on child health, maternal health, and family planning programs. So the question we want to pose to you is, India is currently running the largest program in childhood pneumonia prevention and treatment, which is being implemented for millions of children, so at a huge scale. And there's guidelines, training modules, operational tools, and guidelines. But we can see from the framework from RTI that there still could be a gap between the evidence-based guidelines and what the providers actually practice. So we'd like to hear your thoughts on trying to throw some light on the government initiatives to try and address these gaps in childhood pneumonia management, and your experience of implementing the program.
Thank you. I extend my warm greetings to all the panelists and who all are listening now. So, as rightly pointed out, the challenges of childhood pneumonia that presently India faces is quite huge. We have, under 5 population, about 10% of population in under 5 age group, and every year we add some 26 million to it. And in under 5 age group, 14% actually mortality, pneumonia is the culprit. And to elevate mortality, the severity, and if you take the real incidence prevalence, it's a huge thing. So gaps, already the studies, the earlier studies, it did venture into certain gaps, but I would say that gaps do exist even before knowledge. With the treatment-seeking behavior of our community, bringing the child too late or seeking help or seeking attendance. So gap starts from there. And as rightly pointed out by my previous speakers, there is a lot of knowledge gap also. And the most, the question that has been posed, that knowledge and, the skill part, that gap again, considerable, and can and do gap, of course, the practice is again. So as already pointed out, there are various levels of workers. India's have gone to community outreach to begin with, to tackle the strategies to tackle pneumonia from the communities only. And already the study showed that ASHA, our peripheral level workers, they go into the community for diagnosis. So the strategy here is, to train them appropriately so that they know the basic science and they can refer, if they feel any doubt. So the first management comes with their diagnosing or suspecting and also giving a pre-referral dose of antibiotic that has been given in our guidelines. So that from there, the management starts, and when then they are referred, and our providers, they are trained in, we will say we have extended IMCI into IMNCI. Neonates also we have included in that. And to fill the knowledge gap, recently we have modified our guidelines very recently with group of experts. Coming to the knowledge and can gap, so that skill part, again, a lot of initiatives have been taken, like skill labs. We have come out with skill labs in every big district hospitals we have, and the training curriculum is there, and skill-based trainings are preferred. The training videos are there. Then offline job aids are there. So a lot of efforts are on that the proper skill develops. But as we all know, diagnosis pneumonia, it is a challenge in a way, from how we can change, how we can, really differentiate between the symptoms of, simple nose blockade in a child, especially, more breathing due to blockage or upper respiratory, and filtering out from really, at what point it is turning serious, at what point we need to intervene, because COVID situation has shown us, we should know where, to start. Even simple small things, creating panic, creating everything, that again gives rise to a separate set of problems. So our efforts are that a lot of community awareness generation, strengthening our IMNCI, training, and our support to the states for that, plus having offline job aids. Having already, it has been said by our previous speakers. So we do have supervised visits, like our ASHAs. There are mentors like ASHA facilitators. Then a new cadre of healthcare providers are coming up in India. They are known as community health workers, with higher skill, and they are placed at all our peripheral facilities of sub-centers and health and wellness centers. But they are trained nurses and also alternate system medicine who are trained for that, managing those, almost 1 and 1.5 lakhs are coming up. So those kind of interventions are in process. So a separate cadre is there who can be referred to, who can take the initial management. Another most important thing which have come up during COVID is, teleconsultation, telephonically, if you are not sure of the treatment, then you can consult. That kind of system has been kept in place. Another interesting thing for doing this gap knowledge can do gap is support system, decision support system, like use of chat bots, where it will guide you through a process, into the, finally diagnosing, and also, getting the diagnostic tests also. So that kind of system also we are developing, so that they are supported in this decision making through simple, simple system algorithm, which can actually guide them through. Yes, we have this structure wise, and we have given this pulse oximeter at every, till the lowest level of our facility. They are there, handheld pulse oximeter to, support their decision making. So various efforts are on, and still we know it is a challenge, because add to the magnitude, also add that it's a huge vast country with, all different level of units, our states, which are actually our implementing units, and they are at various levels. Some of them are quite advanced, some of them are not so good, and within that state also there are very much district differentials. So you have to have all the challenge, and there is no simple 1 point formula for that. We try to do in a very in a manner which will serve the general purpose also, and as well as the specific contextualized purpose. So that way we want to handle pneumonia challenge. We have our SARS program, which is coming up on 12th, and this is actually a 4-month-old program and multi-pronged program, like awareness generation, capacity building, then early diagnosis, catching up, early screening, and this time we are going big way into vaccination, our conjugate vaccination. So all we have clubbed together for our 4-month-long campaign, so that we can actually do some impact, especially in the post-COVID area. We know now our systems are strengthened with oxygens and other supplies. So we now want to catch pneumonia early and do the needful.
Thank you. Thank you. And a really comprehensive overview of what's going on, and really nice to see some themes starting to come across between India and Tanzania. I'm going to go to our next speaker, for Dr. Priyananda, who isn't going to be able to stay for the whole time. So it'd be nice to get on to her next before she has to leave. Dr. Priya is a senior program officer in the Bill and Melinda Gates Foundation in the India office, and she holds a PhD in health economics and a master's in international affairs. And she leads the measurement and evaluation work for health systems, reproductive health, and social norms and equity. She's also adjunct faculty in the Department of Maternal and Child Health at the University of North Carolina. So the question we'd like to pose to you is that quality of care is clearly still a major challenge in pneumonia case management. And one of the issues is we do not always understand the drivers or reasons for this no-can-do gap, which makes identifying effective interventions challenging. In the context of pneumonia, do we need more information on the drivers, or do we just need to identify the effective interventions?
So thanks a lot, Carina. Can you hear me? Firstly, just a sound check. Okay. And thank you for very, very wonderful studies, very thought-provoking, and also the previous panelists. I'm going to actually just step back a little bit. I've been thinking a lot about performance of health workers. I mean, the real issue is, why do we see this poor performance, right? Despite trying to do everything that we can to improve capacities and knowledge. But what you see is all the gaps, the no-do and the can-do gaps. And that really is an issue of performance. So what are the drivers of poor performance in the health system? And I think what for me has been really instructive is some of the recent work that my partners have been doing on health systems research. One is the framing of health systems as a kind of complex adaptive systems, which comprises not just of the hardware, which is where a lot of our efforts seem to be, you know, the inputs, skills, capacities, equipment, diagnosis. So not just the hardware, but actually the software, which again comprises of both tangible and intangible software. So tangible software would include training and capacity building, but the intangible software are the norms, the ideologies, the culture of the facilities. And I think Dr. Shumita Ghosh actually talked about it in a different frame. I mean, she talked about the context being complex. And really it is this complexity that we need to really unpack. So it's really the interdependencies between the intangible software and the tangible software and the hardware that really then creates what we observe as poor performance and all the data that was shown by the presenters. So the drivers of this, the intangible, the culture, what constitutes culture and what makes for certain kind of perverse relationship dynamics, misuse of power, the act of performing out, but not necessarily performing, the difference between what is de jure and de facto, because the de jure is all the guidelines and the protocols that you're measuring, right? But de facto is what you actually observe, which is in the Tanzania, it's a very clear demonstration of what is meant to be and what actually is. And of course, I mean, methodologically, I think I could go into each of these studies as to what more additional evidence, and I may take 1 or 2 minutes on that later. But really these difference of de jure, de facto, why we observe, a lot of that is happening both in terms of roles and positioning and power of health workers within the ecosystem where they're operating. So if it's within the facility, it's the hierarchy, it's the relationship dynamics, it's whether actually people feel empowered and motivated, not just do they have the skills and the capacities. And in the communities, because it gets even more complex, health systems are actually connected. Communities are connected tissues of the health systems. So, and a health worker, community health worker really navigates and brokers those relationships. So her role gets even more complicated because of her status in the community, how she's perceived, how she's treated. And so if we are talking about home management of childhood infections and sicknesses, and it is possible she's not visiting all the households, right? She's not screening accurately. There's issues of caste. It might be something to do with the sex of the gender of the child. There are other cultural etiologies that are determining whether a household is open to those visits or not. And that also determines the care-seeking pattern. So what we didn't see in these presentations is the demand side. How does the community expectations of higher quality, of better care for their newborns or for sick children actually affect the quality and the improved diagnosis? The other thing that we don't observe is what's happening in the private sector. The private sector in India, of course, is extremely heterogeneous, but we know actually a lot of care seeking for infectious illnesses happens in the private sector. So we don't know here how much of care seeking is being diverted to the private sector and how much is the public sector being bypassed. But obviously the public sector is signaling very poor quality. And the private sector actually probably has equally poor quality, but there is more trust of the private sector. So in effect, there may be more traffic being generated. And because there's indiscriminate use of antibiotics, as was suggested even in Tanzania, some closure is there on the episodic illnesses. So I think there's a lot of complexity or dynamism here which hasn't been unpacked in these presentations. But the point I still want to make is, one is that relationship or the dynamic nature of care seeking and the relationship with people who are seeking care and their trust in the system. But two is what is happening within the system and the need to really unpack that. I think I also just wanted to make one other point just in terms of the health worker herself or himself. It's largely a she, so I'm using her. What we've also been using is this whole framework of means, motives, and opportunities, which suggests that actually a lot of our work focuses on means, creating the means. But really, how much do our interventions looks at motives, which are really the opportunities, the resources that are being created, incentives, the motivation, and that the nexus of that within a system is with this ideas around intangible software, right? And also the opportunities. So it's means is really where much of our discussion so far has focused. But then what we haven't focused on is how do you create interventions that improve the quality of motives, which is coming from supervision, mentorship, leadership, and then opportunities. Really, what are the resources? Do I have control over my own roster? Can I manage my own time effectively? How much punity is there in the system? How much one-way accountability is driving my performance? So, there are larger issues which are there in the health systems literature, which I think are really coming up in a big way. What would be nice is to kind of start embracing some of that complexity in the research that we are doing. But I think my time is over. So I just wanted to make these brief comments.
Thank you. Thank you so much. And I think a really nice segue that you brought up the private sector in your response, because now we get to hear from Ms. Sakina Baker, who comes from Philips. So it's really nice to see that segue was brought in. And I'm really sorry, Sakina and Anna, but we would love to get some of these great audience questions in at the end. So if you can keep your answers brief so that we can there's been fantastic questions in the Q&A. So we'd really love to get to those. So Ms. Sakina Baker heads the Corporate Social Responsibility program at Philips in India. And in 2019, under her leadership, the campaign Har Sans Main Zindagi, which I've definitely said wrong, was initiated by Philips India to promote awareness and prevention on childhood pneumonia. And her work focuses on building strategic connections of CSR with nonprofit sector through sustained collaboration and capacity building. So the question we've got for you is, historically, donors have provided relatively low amounts of funding for pneumonia, and in particular for health systems interventions like we've been talking about today. So what role do you think donors can play in supporting governments to address some of the issues that have come up today?
Yeah, thanks for the question. I think it's very common to understand that private sector, when people talk about CSR and funders and funding organizations who focus on health. So I think more or less it has not been seen as a health concern which needs focused attention, which needs focused interventions by the corporate sector, by the funding organizations. It has usually been seen as a small part of the entire health gamut. So it gets somehow addressed in bits and pieces, but not really focused. Until the focus is put on the mortalities that are a result of childhood pneumonia. That is what lacks in understanding. It's not that they don't want to, or the corporate or the funding organization, they don't want to invest in it. The focus is on where we are in terms of the children or lives of children who gets lost every year. It's huge. 14% is not a small number. And if it's something that gets generated, thanks to government's initiatives, SARS campaign that has also tried to put in the perspective to this problem that is far more in rural areas, but not less in urban as well. So if you look at it from the perspective, from thought process of the first responders, the people who actually take care of the child, they don't understand the difference. They don't understand where the difference lies. I'm not even sure they are even trained when the mother is expecting that this is something that should prevent the child from. And I think the problem lies not with how remote a part or a location is, it lies with how do we understand pneumonia? How do we understand what it is for a child? How do we take care of it at the first responder level? The second issue that I feel for the corporate sector and the donor is that there has to be constant understanding of this as a huge health concern, like we did with preventing diarrhea campaign. Huge amount of funding went into it. It was only after a lot of interventions by non-profits and profit organizations that people started looking at it as a separate intervention that has to be addressed separately. In our case, also when we did our SaaS Zindagi campaign in India in 2019, I think we were also stuck with understanding what is it that we would want to eventually focus on? What do we really want to get out of it? So we had to do a multiple level of conversations and implementations and initiatives that we looked at from that perspective, whether it was awareness, whether it was creating tools which are for the benefit of the community and case management of childhood pneumonia by the frontline healthcare workers, or just knowledge building of the first responders or the frontline healthcare workers through behavioral change communication tools. I think that was why there's a different set of interventions that has been created, not only for the benefit of the community, but also ensuring that they have a lot more collaborations by funding organizations coming forward and taking it up. So as an organization, as an entity, as Philips, we can do a little bit, we cannot do everything. So a lot more collaborations have to come into play when it comes to dealing with something which is as large as childhood pneumonia in India, and the kind of lives that we lose, which can be prevented very easily if you look at the last mile and you look at what are the interventions that have to be done besides the medication and caregiving. What is the awareness that is provided? What's the training that has to be provided to the frontline healthcare workers? So if we look at each aspect of it in terms of training, awareness, interventions, care, medicines, there's plethora of interventions where the corporates and funding organizations then come in and intervene, and they also fill in their own focus wherever they are looking at from a healthcare perspective. And I believe post-COVID, a lot of organizations who never used to actually invest in healthcare are more keen in doing so, are more keen in looking at healthcare, more keen in looking at how they can participate in the larger process, making sure that not only the infrastructure of healthcare is improved in the country, but also awareness, skilling, training gets improved. And that's a good thing. And if we are able to tab on that, change mindset of the donors, and I think we should be able to do a much better job now that the government is also on board with the SaaS campaign. Obviously, we should piggyback on that, making sure that we put our forces behind that intervention and make sure that it gets picked up, scaled up at the right places, especially at high incidence states, which have huge numbers hitting every year. So COVID has added to those numbers. And I think this is the right time for us to look at what are the kind of collaborations and platforms that we need to come together on and make sure that this doesn't stay as a one corporate intervention, but it goes beyond that. One more important point that I feel that we always ignore is investing in social entrepreneurs. So those innovators who are small-time innovators, but they have really nice solutions for childhood pneumonia. And why corporates and the donors should make sure that they listen and understand what they have to offer and make sure that they are able to help them scale, help them put those innovations out in the open and make sure that they are getting the right kind of attention that is required, especially when it comes to childhood pneumonia. I think these all things is a combination. I don't say there's a one magic wand that will help childhood pneumonia. It's a combination where you look at each set separately and make sure that you are able to invest in that particular aspect, including the private healthcare providers as well. We know that a lot of people, 70% of our population ends up getting treatment from them. But if you really look at it from their interventions, what they do, and maybe get associated with them in somehow and make sure that they are also part of the primary health system in one way or the other, I think it should help at that level. And yes, it goes without saying, it has to be a bottom-up approach rather than us doing something, creating something for the community without the community being in the picture. So I think all the funders should have that view, because India is a very dynamic country. Every 100 miles, everything changes. Dresses, language, way of behaving, culture, food, even medical, the way you go and treat your children or your family members, from quakes to the local level doctors, everything changes. So it has to be a very customized approach for different locations. And I think the funders and donors can come play a very good part if they are a part of those initiatives from the beginning, not just jump in as only funders, but making sure that they're an active participant in the whole.
Thank you. I think that's a really nice message. I'm going to have to stop you at that point, but some really nice points there about collaboration as well, which I think leads nicely on to our final panelist, Dr. Anna Ditchin, who works as a child health specialist for integrated service delivery at the UNICEF headquarters. And in this role, she coordinates efforts to accelerate progress in child survival, focusing on coverage and quality of care, while at the same time providing guidance towards broadening child and adolescent health programming to ensure universal and targeted health and development interventions throughout the life course. So a great partner to have on everything. So the question I want to pose to you then, kind of listening to everybody else respond, what role can a global leader like UNICEF play in supporting countries as they grapple with misdiagnosis?
Yeah, thanks, Carina. And indeed, a lot of great things have already been said. And I think we all know that there are massive gaps in the quality of delivering child health services at every level, but maybe particularly as we've seen in the presentations in the context of frontline services such as IMNCI, but also community-based care. So I think the most important investment in action is now to really use all this evidence that we have from many different contexts to ensure that the right mechanisms and processes are put in place that address these quality gaps and that these are budgeted for. I think someone raised that in the question and answers. We still want to understand why a misdiagnosis takes place, but maybe not as part of sort of formalized research, but as part of quality assurance and quality improvement activities that are aimed at identifying context-specific issues and then the right local solutions for those. So in addition, we need to strengthen the system, and Priya has nicely spoken to that, and really institutionalize those efforts, that we monitor health worker performance and their adherence to diagnostic and treatment guidelines, that we collect the right local data and empower health workers to review and use their data to identify and address these bottlenecks. I think that there are really good opportunities that we can build on, as quality of care has really received increased attention over the past years through the Quality of Care Network and other efforts. Countries have put in place quality units and management teams at national and subnational levels. In the context of maternal, newborn, and child health, the focus so far has been very much on improving maternal and newborn quality of care, especially at the hospital level. But we do have standards for quality of care for children and young adolescents. And these standards were developed very much around key child survival interventions and address all those factors that we talked about today that are really required for fully functional quality child health services at all levels. So the provision of care through capacitated health workers, infrastructure, supply, but also the satisfaction of clients. And the uptake of these standards is advancing rather slowly, partially because indicators for those are still being finalized. But I think there are, things that we as UNICEF, but we all can do in our support and collaboration with countries. So this is to ensure that pediatric quality of care is included in existing efforts, and that these efforts really address quality of care throughout the service continuum. So focusing on the services where the most children seek care, that's the primary healthcare facilities and the community-based services, but also improving referral mechanisms and referral level care. And I think the colleague from Tanzania very impressively, described the scope that means that we really need to address in ensuring that we reach all facilities and all service delivery points with these efforts. We do ideally engage private providers from the onset. As we know, in many countries, a majority of children do seek care in the private sector as the first entry point. We need to move beyond the traditional focus of training health workers towards strengthening mentorship and supervision, but also continued on-site medical education or remote through telehealth, as was mentioned earlier. So I think it's important to address exactly what was shown in the presentations earlier, to address this know and do gap. Only, when we train health workers, they know what they should be doing, but only this continued support and refreshing of this knowledge will ensure that it's solidified and correctly applied. We can explore the added value of digital decision support tools that help health workers to address and adhere to diagnostic and treatment algorithms And then there are diagnostic tools such as pulse oximeters. There was a question related to that. Those have shown to greatly improve the identification and correct management of children with danger signs, but they've also shown to improve the adherence by caregivers to advice given to them for referral or treatment by health workers. I'm mentioning the pulse oximeter specifically because there is a huge opportunity right now with the massive investments in oxygen equipment as part of the COVID response. And it's a chance to engage early and identify the priorities for reallocating some of those supplies and providing the clinical guidance and tools to strengthen their use, for example, in the context of child health programming. If we do want to generate more evidence, I think that we should focus on operational research that complements quality improvement efforts at local level, strengthens the collection and use of local routine data, and is aimed at finding practical solutions in a given context. As to our role as UNICEF, we are very much part of this shift from focusing solely on coverage of effective intervention towards improving quality of care, and are supporting countries in many different ways to do so. The research that was presented today focused on pneumonia, but you all know, that we see pneumonia really as a tracer for well-functioning primary healthcare, and the continued high mortality in pneumonia is truly a symbol for a lot of the bottlenecks in access to and quality of care that require focus and prioritization. So a lot of our country level efforts at UNICEF aim at improving investments in and strengthening systems to deliver quality primary healthcare, both at the facility and community level through integrated service delivery models and improved access to diagnostics and treatments. One last thing I want to share is that at the global level, we are currently working with a number of partners under the Child Health Task Force to ensure some renewed focus, investment, and strengthened collaboration to the child survival agenda. We do feel, I think, that this is a gap that needs a little bit of a push. And as part of this work, we're looking at the framework from the Global Action Plan for Pneumonia and Diarrhea, which really comprehensively lays out the key interventions to address the key causes of under 5 deaths. We're looking at primary healthcare as the platform for delivery. And we are clearly emphasizing within all of that the need for improved quality of care. There'll be more to share on this soon, but I leave it at this for now.
Perfect, thank you. Such a nice overview, and I think highlighted lots of key points that have come through. From the chat, from the Q&A, from the audience, there's been a few themes that have come through, and I'm really happy you touched upon pulse oximetry and devices. So I'm going to pause that one and just end. I think we've got time for one question, and this is open to all panel members. Something that's coming across is whether IMCI as kind of a broad approach is still appropriate and fit for purpose, given we see that we've had this tool for a long time. We're still having issues with implementation. And as many panel members have mentioned, we have very different contexts between private and public, rural, urban, primary, secondary, community level. Is this broad brush approach still what we should be going for? So I'm going to open that to all panel members if you'd like to comment, but please leave your comments to 1 minute. So it's a very quick reaction from everyone.
Carina, can I come in?
Yes.
Yeah, I would like to kind of disagree with the question. So I think in my humble opinion, not having the expertise that others have on the panel, I think the big issues here are not whether a singular bundle or a package or of a screening and diagnostic is effective, but really what is the context and how do we address some of those interdependencies? So it's not about IMCI, but it is IMCI in the context where there are human resource shortages, where health workers don't have the power to control their own rosters, where they don't get supportive supervision, where data is largely of poor quality at best and sometimes manipulated, where there isn't veracity of data that is being used to drive decision making. So it's all of those. So if we really believe that actually it was the data that is going to drive our decisions, and we cared about the quality of data, all of the other things could fall in place. So you just have to take one of these kind of challenges that I'm talking about and then really work through. So it's not about IMCI, it's about everything else. So for me, that's the point I wanted to make. Sorry.
Thank you.
And if I may add to that, Carina, I agree with you, Priya. I also think that the IMCI review that was undertaken in 2016 very clearly showed that we just didn't implement IMCI very well. So while it's taken up by many, many countries, and I think we all believe that that is sort of the core of child survival programming, we haven't paid as much attention to the health system strengthening component that is part of IMCI. We have not paid as much attention to the community engagement and the preventive component that is IMCI. So it is how do we implement these interventions or these packages so that they are actually can be delivered with quality and at scale.
Thank you. And Dr. Ghosh, please.
Yeah, I just one-liner, as you said, we have gone ahead with the pneumonia specific modules, guidance, specific. We have for general, we have IMNCI training, but for tackling pneumonia and capacity building of our workers at various levels, starting from our peripheral ASHA level to the pediatrician level, we have separate guidance and separate trainings. Because it needs, it demands, it merits that we tackle it individually also, capacity building.
Thank you. Really interesting there. So it's kind of taking it, but making sure it's adapted. Any comments from Dr. Ntuli?
Not really for now. Actually, I do appreciate my colleagues for their contributions. Those are massive. But for us, still we have a long way to go in that area, and we welcome different partnerships so that we can be able to help our colleagues who are working at the front line.
Yeah, thank you. Definitely partnerships is coming through very clearly in this call. Dr. Manidi.
Thank you, Carina, once again. I think what I'll say is all the points that we have discussed as a panel, if we take comprehensively each point as it was highlighted, then we're going to improve in terms of the care that we deliver. We should not segment, like only focusing on one tool. Let's have a comprehensive approach as what others have portrayed earlier. Yeah, that's it, as I can say.
Thank you. And then Sakina, if there was any closing comments.
Yeah, I think I agree with everything in terms of what was discussed. The only comment that I will make here is that when we look at childhood pneumonia, let's not get digressed by the fact that we are trying to focus on childhood pneumonia in a way that addresses it, but also try at the same time overlooks the concerns that are a party to it, whether it is anything which is associated with. So why not look at it from the very beginning rather than when it is becoming a problem on the face of it? So partnerships, not just within the system where people are working in child pneumonia space, but also ensuring that we partner with people who are equal stakeholders. May not be directly working on child pneumonia, but they have associations in the health systems which can help improve processes, capacity building, trainings, awareness, everything that we are trying to look at.
Thank you. Yeah, very nice. Holistic, always look holistic, which I think speaks to the core of IMCI. So with that, I'm going to close the panel discussion and thank everybody for really thoughtful contributions and hand over to Dr. Rajiv Tandon to give our closing remarks.
Thank you, Carina. Well, just view of the time, we have actually reached the end, so I'll restrict my comments. It's been an absolutely fantastic discussion, very timely. I think the whole world is going to focus on childhood pneumonia next week onwards. We heard what Tanzania and India are planning, what they are doing, and the openness and agreement that more needs to be done and better. What I think comes out is that there is need for partnership, but also need for knowing how things have to be done. The what seems to be known. There are guidelines, there are modules, there are training methodologies, there is clarity of the algorithmic approach of how do you prevent, how do you diagnose, how do you treat, how do you refer, and so on and so forth. But the real challenge is on how it has to be implemented. And we heard Tanzania tell us its story, and we heard India, two very varied environments in scale, in diversity, in sizes, and so on and so forth. But clearly, there are systemic challenges in the sort of no-do gap and probably approaches that need to be fed into. I think that our panel represented a very varied group of stakeholders, and our moderator, Carina, did a fantastic job. I mean, in such a short time, she ensured that we got a lot of content, a lot of stuff to think on and to work on in future. Between R4D and RTI, we are both organizations wanting and keenly engaged in areas of research, operational research, implementation research, and so on and so forth. And we feel those are huge needs, especially in childhood pneumonia and child health overall. I don't want to take individual names of all the panelists, but I just want to thank everyone who participated and ensured that what comes out is really useful. I also do want to mention folks from both R4D and RTI who were behind the stage, but ensured that we could have such a interesting panel participation, good outcomes, and I want to mention Samantha, Leaf, Prince, Cami for doing all of this and ensuring it really well. We do look forward to staying engaged further, and we do want to take all that has been discussed and shared into the next level, and potentially we are in a phase of a post-COVID, so to say, and how can we see lesser children with pneumonia actually losing their lives and being managed better. So I'll stop there, and I want to thank yet once again everyone and for participation. We had great participants, a lot of questions, and lots that were potentially tried to be answered through the panel discussion, but if not, we will ensure that everyone's questions are appropriately addressed and answered. So a big thank you on behalf of R4D and RTI. Back to you. Carina? Yeah, will you end it? Yeah.
Yeah, and I think with that, that's the end of our webinar today. So thank you everybody for staying, and yeah, hopefully this can lead to some actions going forward. So thank you very much, everyone.
Thank you.
Thank you.